So it's really an honor for me to be chairing this session with Dr. Patrick Servius, who's professor of cardiology and a well-recognized interventional cardiologist currently at National University of Ireland, and with obviously Dr. Srinivas Kumar, who's the organizer of this program, professor of medicine and director of cardiology at Apollo Hospitals in India. We really have an outstanding panel of speakers today. And that includes, maybe I'll introduce all the speakers right now in the interest of time so that we can proceed with our session without further delays. So Dr. Randall Thompson, who is current president of the American Society of Nuclear Cardiology from Kansas City. Then we have Dr. Jamieson Bourke, who is the director of nuclear cardiology at University of Virginia. Then we have Dr. Viviane Taketti, my colleague and the director of the stress lab at Brigham and Women's Hospital in Boston, and an amazing speaker as well. And then in addition, I think Dr. Srinivas Kumar has introduced the speakers from India. And we have Dr. Vikram Lele, who's part of both the ASNIC panel and the panel from India, bridging both groups. So without further ado, I now just invite Dr. Randy Thompson to speak about the value of Spec myocardial perfusion imaging and calcium score in the management of patients with ischemic heart disease. So Randy, please go ahead.
Thank you, Shamala. Thank you for the introduction. And thank you to TCT India, South Asia for inviting us. It's a pleasure to represent ASNIC in this endeavor. I have no disclosures. And for the next 10 minutes or so, I'll talk about the value of Spec myocardial perfusion imaging and identifying the patients that benefit most from your interventional procedures. For those of you who may have trained more than 10 years ago, you may think of nuclear cardiology, cardiac SPECT as something that's kind of stuck in a previous era. It actually is a very dynamic field. There are a number of things that are on the horizon that are very exciting about this technology. I won't read all of these, but one in particular that's close is SPECT quantitation of myocardial blood flow. Dr. Taketti is going to talk a bit about PET flow, but SPECT flow is harder to do, but fairly close. And I think you'll see that nuclear cardiology in particular is moving toward being more quantitative and more use of absolute quantitation of blood flow. But when I think of contemporary MPI SPECT, again, it's not stuck in 1990. We have had incremental benefits improving accuracy and radiation dosage, such as these here. Ultra-low dose radiation, SPECT-only imaging, attenuation correction and advanced post-processing, and improvement in equipment, CZT detectors in particular, but the other angle cameras have also had advances. And what I'll talk about for a few minutes is the concept of combining myocardial perfusion imaging with CT coronary calcium scoring. Before I do though, let me just talk about one of the benefits of SPECT myocardial perfusion imaging above and beyond PET and coronary CTA and even MR, which you'll hear about in subsequent lectures. I just want to remind you that the exercise capacity that a patient has is a very powerful prognosticator. And we've known this for a long time. This study dates back to 1994. But as you see, as the peak O2 uptake increases along the horizontal axis, as exercise capacity goes up, there's a curvilinear decrease in all-cause mortality and cardiovascular mortality. A very powerful prognosticator. Of the many studies on this subject, here's another one from 2002 that I like. This is in men and in people that have known coronary disease or had a positive stress test or normal subjects. There's a big drop-off in mortality when the exercise capacity is less than about 8 meds. So this is not particularly sexy. It's not particularly snazzy and new, but this is something that's very powerful, very useful. It's very relevant today. And you can do exercise with SPECT. It's harder to do with PET. It's not impossible, but harder with the current tracers. And of course, you do not do this with coronary CT angiography or with MR. When you do exercise, you also can reproduce the patient's symptoms, giving you confidence that what you're treating, what your target for treatment is indeed what you think it is. Let me change gears a bit and now talk about the concept of combining SPECT myocardial perfusion imaging with CT. There are instruments that can do this very easily. They're hybrid instruments. They're more common in nuclear medicine departments than nuclear cardiology departments. But we will, in our laboratory, obtain a coronary calcium score on every patient who has a myocardial perfusion imaging study that's a diagnostic study. And here's an example, a case. Here's a patient who had a nice normal myocardial perfusion imaging study. The patient was in the hospital with chest pain, which some doctors thought was atypical, some thought was not so atypical. But the coronary calcium score obtained at the same time was very high, over 3,000. So this patient had severe established coronary artery atherosclerotic disease, but an MPI that was negative. In this case, it was a false negative MPI study. We were happy to have the calcium score because it directed us to go back and talk to the patient, reconsider what our options are. Usually when you have this combination of a normal MPI and heavy coronary calcium, the MPI is a true negative, but what you've done is you've discovered the patient does have significant atherosclerotic disease. And we've known for a long time that coronary calcium does track the atherosclerosis in the coronary arteries. This is a well-traveled slide showing the mortality rate, all-cause mortality rate goes up substantially as the calcium score goes up. That's because you're measuring atherosclerosis in the coronary arteries. When we combine MPI with calcium scoring, we get incremental diagnostic and prognostic information. So for example, on the left, in gold, patients that have a normal MPI with a calcium score of less than 1,000 versus in red, over 1,000. And on the right panel, those who have calcium score above or below 1,000 and have an abnormal MPI study. You just see a big difference in prognosis, whether there's atherosclerotic present or not, on top of whether the patient has ischemia or not. So with our MPI study, we determine whether the patient has ischemia, obstructive coronary disease causing the symptoms perhaps. And with the calcium score, we determine whether there's significant and how much underlying atherosclerotic disease there is. This has been tested on a diagnostic value. The gold line is combination of Framingham risk score, Spec results, and calcium scoring. That has the largest area under the curve. And I believe this is an underestimation because, quite frankly, when we see a lot of coronary calcium, we read for sensitivity, and when we don't see much, we read for specificity. So we're better able to decide which patients need the interventional treatments that you all give. And physicians change medical therapy. When there's normal myocardial perfusion, but significant coronary calcium, doctors do put patients on statins and ask them to use that for treatment in 2 studies, actually multiple studies now, which makes sense. You've got atherosclerosis, you've identified someone who has a prognosis that's going to be affected by their coronary atherosclerosis. It makes sense to kick in different follow-up algorithms, different responses when the patient's symptoms change, and more aggressive preventive therapies. Now, quite frankly, most of the evidence that we have that the patients with no ischemia and significant coronary calcium benefit from statins and other treatments is inferential. But for example, this study from the confirmed database of coronary CT angiography, those who had non-obstructive coronary artery disease and were treated with statins had better MACE results than those who were not treated with statins, which makes sense and is consistent with the other things we know about this disease. Let me call your attention to one other study that came out early this year regarding the effect of coronary stenosis versus the atherosclerotic burden as measured by the coronary calcium score. It's really emerges that most of the information regarding prognosis is in the calcium score rather than all the other things that are in a coronary CT angiogram. We'll hear more about the coronary CT angiogram shortly. But if you take the number of whether or not there are obstructive coronary lesions grouped on how much atherosclerotic disease there is based on the coronary calcium score, whether there's 0 calcium, a little bit of calcium, an intermediate amount, or a lot of calcium, the outcome curves are almost exactly the same. And what these authors concluded was that plaque burden, not stenosis per se, is the main predictor of risk for cardiovascular events and death. Thus, patients with a comparable calcified atherosclerotic burden generally carry a similar risk of cardiovascular events, regardless of whether they have non-obstructive or obstructive coronary artery disease. Isn't that interesting? That this metric that we've been talking about for a while is that powerful, even more than whether they're obstructive lesions or not. And now, when we obtain our formal calcium score in my laboratory, and again, we do this in every MPI case that's diagnostic, on an instrumentation where there's a Spec CT machine, you get a CT attenuation map, with each of the transmission maps. But we will perform a separate coronary calcium score. Now, to obtain the calcium score actually requires more expensive equipment. The manufacturers require a more expensive CT scanner. As part of the hybrid machine, one has to have the calcium scoring software and a gating package. But what you can do is you can eyeball the CT attenuation maps and get a lot of the same information. And here's a study that came out earlier this year about the visually estimated coronary artery calcium score. This is from a non-gated study, and how it also improves the SPECT MPI risk stratification. In other words, this is the eyeball test. This is a nice large study, over 4,000 patients, and they concluded that visually estimated coronary artery calcium score was an independent predictor of major adverse cardiac events in this large SPECT MPI cohort, that VCACs from CT attenuation correction can be used to improve risk stratification with SPECT without additional radiation. And here are the curves. Now, and they did not distinguish these in a very sophisticated fashion, and they weren't even particularly highly trained readers. But if you have extensive coronary calcium on this non-gated visual estimate versus absent versus equivocal or present, it made a big difference in the outcomes. And those incremental prognostic value based on whether there was myocardial perfusion imaging defects. So some stress score of 0 is no defects. Some stress score of 12 is a lot of defects. As you see, there's an incremental defect, incremental progression. The more calcium there is, the more the defects there are, the worse the patients do. And here it is with a normal stress perfusion, an abnormal stress perfusion on the upper panel, no history of CAD or known history of CAD. So in summary, contemporary SPECT MPI closes the gap between the advanced imaging modalities, such as PET that you can hear about shortly. Exercise response is powerfully prognostic and diagnostically. And routine addition of coronary calcium scoring or visually estimated coronary artery calcium to SPECT MPI improves case detection, diagnostic confidence, prognostic power, and frequently alters management. And I would encourage you to encourage your imaging colleagues to embrace that sort of combined approach. Thank you for your attention.
Thank you very much, Randy. That is perfect. And you also made it in time. Thank you.